Hello, my dear future doctors, and welcome back to class. Today we are tackling a big one, general anesthetics. I know, when you see that long list of drugs, the chapter can feel a bit intimidating. But don't you worry, we are going to make it very, very simple. Let's get started.
You know, when you first open your textbook, you see this long list of names, no? Halothane, isoflurane, thiopentone, propofol. It's just a lot. But listen, the secret is not to memorize that list. The real secret is to understand the concepts behind them. And that is exactly what we are going to do today. We'll build a mental map, and you'll see how everything just clicks into place.
So, to begin our journey, we need a map. Just think of all general anesthetics as being located on one of two main roads. If you understand these two roads, trust me, you've understood the master plan of this entire chapter.
Okay, now have a look at this. This slide really simplifies everything. See here, on one side we have the inhalational route. These are the drugs you breathe in, and they can be either gases like our old friend nitrous oxide, or they can be volatile liquids like ether and sevoflurane. And on the other side, we have the intravenous route. Now these are divided into the fast-acting drugs like thiopentone, which we'll focus on today, and some other slower-acting groups. This chart, my friends, this is your key. Keep this mental picture with you.
Okay, so let's focus on that first road, the inhalational agents. A big question is, why are some so fast to put you to sleep while others are so slow? Well, the answer lies in one single beautiful property. Let's find out what that is.
Please, everyone, underline this in your minds. For your theory exams, for your Viva, for your future clinical practice, this is the golden rule. The speed of an inhaled anesthetic, both for going to sleep and for waking up, is all about how soluble it is in the blood. So the point is this, if you understand solubility, you understand half the chapter right there.
Now, when we talk about solubility, we use a specific number. It's called the blood-gas partition coefficient. It sounds very complicated, doesn't it? But it's actually very simple. Think of it as just a number that tells us how much the drug loves to be dissolved in the blood compared to being a gas in the lungs. A high number means it loves the blood. A low number means, well, it prefers to stay as a gas. That's it.
And this slide just illustrates that inverse relationship perfectly. Think of it like this. If a drug is highly soluble with a high Bg coefficient, the blood is like a giant sponge. It just keeps soaking up the drug, and it takes a long time for the blood to get saturated enough for the drug to finally reach the brain. But if a drug has low solubility, a low Bg coefficient, the blood gets saturated almost instantly. The drug can't hide in the blood, so it rushes to the brain. What does that mean? Fast induction and fast recovery. Simple.
All right, so with that core concept firmly in our minds, let's take a quick tour of the actual drugs themselves. We'll see how this principle of solubility plays out with some real-world examples.
So on your screen, you can see two examples. On one side, we have halothane, an older but very important agent, and on the other, sevoflurane, which is much newer. You know, the whole story of modern anesthetic development has basically been a quest to create drugs with lower and lower blood solubility. And why is that? Because lower solubility means faster action and, more importantly, more control for the anesthesiast.
This table is perfect for your Viva prep. Just look at the pattern. Ether, the old one, a huge Bg coefficient of 12.1, so induction is very slow. Now come down the list with me. Halothane, 2.3, intermediate. Sevoflurane, 0.68, fast. And look at nitrous oxide at the very bottom, a tiny 0.47. It's super fast. You see? It's a perfect inverse relationship. Higher the number, slower the drug. Lower the number, faster the drug. Got it? Excellent.
And speaking of nitrous oxide, it's a bit of a special case. It's a fantastic painkiller, a good analgesic, but a pretty weak anesthetic. For your exams, just remember two unique phenomena associated with it, the second gas effect and diffusion hypoxia. Just keep those two concepts in your notes. They are very important. Okay, so we've traveled down the inhalational road. Now, let's switch lanes completely and get on the expressway, the intravenous route. These are the drugs that work with incredible speed. How fast, you ask? About this fast. 11 seconds. That's the approximate arm-brain circulation time. That's the time it takes for blood to travel from a vein in your arm, through your heart and lungs, and all the way up to your brain. When you inject these drugs, they produce unconsciousness in just one of these circuits. It's really quite amazing when you think about it.
And the classic drug for this is thiopentone. Its secret is not just being injected directly into the blood, its real secret is its extremely high lipid solubility. The brain is a very fatty organ, right? And thiopentone, being so lipid soluble, just crosses from the blood into the brain almost instantaneously. And that's what gives it that rapid knockout effect.
But here's the clever part. Why do you wake up so fast? In just 6–10 minutes. It's not because the body has eliminated the drug. No. It's because of something called redistribution. See, the drug first floods the brain because the brain gets so much blood flow. But then, slowly, it starts to leave the brain and distribute itself to other tissues, like muscle and fat. And as the concentration in the brain drops, the patient wakes up. The drug is still in the body, mind you, but it's hiding in the fat and muscle, not in the brain. A very, very important concept.
Now, while thiopentone is the classic, the modern king of IV induction is definitely propofol. It acts just as fast, but the big advantage is that it is metabolized much more quickly. This means recovery is not just fast, it's also very clear and crisp, with less of a hangover effect. This makes it fantastic for outpatient or daycare surgery, where patients need to go home the same day. So we've seen so many drugs: inhalational, intravenous, fast, slow. Which brings us to a final logical question. Why do we need so many? Why not just have one perfect, ideal anesthetic? Well, let's see what that would even look like. You see, this slide shows the ultimate wish list for an anesthesia. For the patient, it should be a pleasant experience. For the surgeon, it needs to create perfect operating conditions. And for the anesthetist, it must be safe and controllable. The truth is, no single drug in existence ticks all of these boxes. Ether provides great muscle relaxation, but it's slow and explosive. Nitrous oxide is a great analgesic, but it's weak. Propofol is fast, but it can drop the blood pressure. That's why anesthesia is an art. It's about choosing and combining the right drugs for the right patient and the right surgery. And that brings us to our final thought for today. We have all these wonderful, powerful drugs, each with its own strengths and weaknesses. So in the operating theater, with a patient's life on the line, what truly matters more? The specific chemical in the vial, or the knowledge, the skill, and the vigilance of the doctor administering it? That is something to think about. We'll see you in the next class.
Hello, my dear students, and welcome. Today, we're going to talk about something absolutely crucial in medicine. Think of it like the opening act of a grand performance. We are, of course, talking about pre-anesthetic medication, the symphony before the surgery.
So let's start with a question. Just imagine for a second, what is a patient's absolute worst nightmare? It's being aware during surgery, right? A terrifying thought. So what is the very first thing we do to make sure this never, ever happens? Well, the answer lies in what we do before the anesthesia even begins. So here's our plan for today. First, we'll understand why this pre-medication is so important. Then we'll look at the actual drugs we use, the doctor's toolkit. After that, we'll tackle the tricky part, drug interactions, and then the potential complications. And finally, we'll put it all together to see the big picture. Cello, let's begin.
Okay, first things first, why is pre-medication so key? You see, this is not just some optional step. This is the foundation. It's setting the stage properly so that the entire procedure is as safe and smooth as possible.
So what are we actually trying to achieve here? What are our goals? You can see the 6 main aims on this slide. Think of it like this. First, we take care of the patient's mind. We relieve their anxiety and create amnesia so they are calm and won't have any distressing memories. Then we protect the body. We add to the pain relief, we reduce saliva and other secretions, we stop them from feeling sick afterwards, and very importantly, we make the stomach acid less dangerous. It's all about total control and total patient safety.
Right, so now that we know why we're doing this, let's look at what we're using. We're moving on to the doctor's toolkit. And remember, this is not a one-size-fits-all approach. We have to choose the right drugs for the right patient every single time.
And the first most important tools in our kit are the benzodiazepines. You know these names: diazepam, lorazepam, midazolam. Their job is simple but vital. They make the patient calm, and they produce amnesia for all the events around the surgery. The best part? They help us start the anesthesia smoothly without causing major breathing problems. These are really our workhorse drugs for tackling patient fear.
Next up, we have the opioids. Now, these are what you'd call a double-edged sword. On the one hand, they're fantastic for severe anxiety and give amazing pain relief. But, and this is a big but, look at the disadvantages. They can suppress breathing, drop the blood pressure, slow down recovery, and cause nausea and constipation later. This is exactly why we don't use them routinely for everyone anymore. They are reserved for patients who are already in a lot of pain before they even get to the operating theater.
Okay, now for a very interesting problem. During surgery, the body can sometimes produce a lot of saliva and other secretions. This isn't just messy, it can be dangerous. It can trigger reflexes that slow the heart down, which we call vagal bradycardia, or even cause the vocal cords to clamp shut, a laryngospism, which can block the airway. So how do we stop this? The solution is a class of drugs called anticholinergics.
And when we talk about anticholinergics, we mainly have two options, atropine and glycopyrrolate. Let's just compare them quickly. As you can see, glycopyrrolate is stronger at drying up secretions. It causes less of that fast heart rate or tachycardia. And this is the most important point. It has no effects on the brain or central nervous system. Because of these advantages, glycopyrrolate is what we prefer to use in modern practice.
Another huge risk we need to prevent is something called aspiration pneumonia. This is what happens if the contents of the stomach, which are very acidic, accidentally go into the lungs. It's a very, very serious complication. So what do? We give simple drugs like ranitidine or omeprazole beforehand. These drugs increase the pH of the stomach juice, making it much less acidic and far less damaging if it does get into the lungs. It's a simple precaution, but it's a lifesaver.
And of course, post-operative nausea and vomiting, PONV. Nobody wants to wake up feeling sick. To prevent this, we use drugs called antiemetics. Now, while we have a few options, the clear winner in modern medicine is ondansetron. It is incredibly effective, has very few side effects, and makes the patient's recovery so much more comfortable.
All right, so we have our toolkit of drugs ready. But now we have to navigate the obstacle course. You see, the patient is not a blank canvas. They often come to us already taking other medications for other conditions, and we have to be extremely aware of this.
For example, let's say your patient is taking medicines for high blood pressure. What do you need to know? You must be prepared for a significant drop in their blood pressure when you give the general anesthetic. We have to anticipate this and be ready to manage it immediately.
Now this one is absolutely critical. Please pay close attention. If a patient is on long-term corticosteroids, the stress of surgery can be too much for their body to handle. If we don't give them an extra stress dose of hydrocortisone, they can go into cardiovascular collapse. This is a non-negotiable, must-do safety step.
And what about our diabetic patients? It's interesting, but during the stress of surgery, their body's need for insulin actually goes up. So the rule is very clear. Even if they take tablets at home, for the surgery they must be switched over to plain insulin. This is to maintain tight control of their blood sugar and prevent any dangerous complications.
Now, even with the best planning in the world, we have to be honest and acknowledge the risks. So let's quickly look at the potential complications that can happen, both during the anesthesia and after the surgery is over.
During the procedure itself, the whole team is on high alert. We've talked about awareness, the most dreaded complication. But we also watch for delirium, convulsions, and those dangerous reflexes we discussed earlier, like vagal stimulation or laryngospism. Everything we do with our pre-medication is designed to prevent these exact events.
And the risk isn't over when the patient leaves the OT. In the recovery period, other issues can pop up. Nausea is common. Sometimes the sedation can last too long. More seriously, there are risks of pneumonia or damage to organs like the liver or kidney. And especially in our elderly patients, we have to watch out for confusion as they wake up, something called emergence delirium. So post-op care is just as important.
So let's just take a step back and look at the big picture. I hope by now it's very clear to all of you that anesthesia is not just about giving one injection. It's a continuous, dynamic, and carefully managed process. From the moment we give that first pre-medication all the way through to a full recovery, we are performing a delicate balancing act. We're balancing the patient's comfort, their absolute safety, and the needs of the surgeon. It truly is a testament to deep pharmacological knowledge and very, very meticulous planning.
So I'll leave you with this final question to think about. Is anesthesia just a single magic bullet that puts someone to sleep? Or is it something much more beautiful, a carefully conducted symphony, where every single drug, every single action is a musical note that must be played at the perfect time and in perfect harmony? I think you know the answer. Thank you.